Dr. Martine McGrath. Dr. McGrath is a transplant nephrologist and the medical director of live kidney donation at Brigham Women's Hospital. She is active in education, in particular at the medical school for postgraduate education, and is the medical editor of the Trends in Medicine blog for Harvard Medical School. We're very happy to have her today to speak a little bit more about urine sediment and glomerular disease. Thank you.
Great. Thanks very much. Welcome, everyone. This is me. And these are my disclosures, none of which are relevant to this particular talk. So over the next few minutes, we will talk about the benefits and limitations of carrying out a urine sediment analysis. We'll describe the utility of using renal tubular epithelial cells and granular casts in AKI diagnosis and prognosis. We'll go through some cases of leukocyturia and talk about the significance and evaluation of isolated microscopic hematuria. So if you think about the urine sediment, it actually carries many of the characteristics one would consider of a biomarker of kidney disease. It is cheap, it's readily available, it's quite reproducible. It indicates the presence of renal injury, and changes on the urine sediment can also suggest the compartment of injury. The data may alter the treatment plan, and the sediment can be particularly helpful in differentiating between prerenal states and acute tubular necrosis. And there is some data that I'll show you to suggest that greater degrees of renal injury on the sediment may correlate with more severe acute kidney injury and need for future renal replacement therapy. So thinking about the urine sediment as a biomarker and what, I guess, components of it may tell us about different compartments of the kidney. So if you, in this diagram, if you look at the urine sediment components are in the purple boxes versus the traditional biomarkers we think about in kidney disease are in the green. So if we look at the glomerulus, in the green here, we have serum creatinine, we have cystatin C, we have albuminuria, but in the urine sediment, we can look at red cells and red cell casts, which can be quite specific for glomerular injury. As we move along the renal tubule, biomarkers like KIM1, NGAL, TIMP2 have been validated for acute kidney injury, but the presence of renal tubular epithelial cells, renal tubular epithelial cell casts, or granular casts can also indicate tubular injury. In the interstitium, the presence of white cells and white cell casts are really the only biomarker that we have to date in terms of looking at kidney injury. So I think, there's something to be said for thinking about the urine sediment as one of the tools that we use when we assess patients. So Mark Parzella has done quite a lot of work to try to formalize how we use the urine sediment in caring for patients with acute kidney injury. So he came up with this scoring system based on the presence of renal tubular epithelial cells, RTEC casts, and granular casts in the urine, with the goal of assessing the ability to predict worsening AKI. And the urine was assessed by renal consultants who had been trained in what they were looking for in the urine sediment. And then there was a second nephrologist who was blinded to look at the chart and agree on what the diagnosis was. So they enrolled 197 patients with a kidney stage 1 to 3 acute kidney injury, 134 of which were adjudicated to have ATN and 63 had prerenal AKI. This is what they were looking for, is the renal tubular epithelial cells on the left versus the granular casts on the right. And the scoring system was quite simple. It looked at renal tubular epithelial cells per high-powered field between 0 or greater than 6, and granular casts per low-power field between 0 and again greater than 6. And a grid scoring system is shown here, where those with the most abnormal urine sediment got a maximum score of 4. And so essentially baseline higher urinary sediment score correlated with higher akin stage AKI. But what was quite interesting was that higher urine sediment score also correlated with worsening acute kidney injury during follow-up. So if they used those with a urine sediment score of 0 as the reference, there was an increasing relative risk with higher sediment scores with a relative risk of 7 than those who had the score greater than 3. So certainly some predictive value in this particular cohort of patients. A number of other investigators have tried to come up with similar similar studies and with varying degrees of success. And I think what's informative about these different studies that I'm showing here is if you look at the study population that are involved, there is a variation in how useful the urine sediment is in predictive value. So if we go back to this quite old study from 1979, this was ICU patients with a relatively those that showed urine casts had higher rates of worsening kidney injury. Similarly, the Chowla paper, the Parazella paper in itself, these scoring systems had an AUC of about 0.7 to 0.8. However, if you look at Shinstock's study of patients in the emergency room, this was a larger study of acute kidney injury patients, and this had quite a low AUC, which was specific for acute kidney injury, but with low sensitivity. And I think perhaps like any screening test, if we're going to use this, it depends on the pretest probability of how likely it is that the AKI may get worse in future as to how useful these predictive values can be. So certainly for patients who are in the ICU, there seems to be some utility, but perhaps less so in those who are in less severe acute care settings. So one of the things that always comes up is that what I see on the urine sediment is different to what's reported from the lab exam. And actually, there are good technical reasons why that is the case. So how we as nephrologists examine the urine differs to how a lab sediment is done. So the volume of urine that's used is different. The speed of the centrifuge, the resuspension volume, and the suspension of volume that is actually examined differs between these two approaches. Nephrologists use a much more concentrated sample of urine, which gives you a higher yield of renal tubular epithelial cells, dysmorphic cells, and casts, versus the laboratories are actually CLIA certified based on their ability to produce an accurate urine white cell count and red cell count. And so they use a much more dilute urine sample, which reduces the likelihood that they're going to see urine casts. However, a number of different groups have tried to come up with protocols to improve the yield of the urine sediment and to improve the identification of individual cellular elements. This is one study from Korea from 2017, where they used a protocol using light microscopy and staining of the urine sediment to try to make the elements easier to identify. I put up this slide because these top 14 panels here are all adjudicated to be isomorphic red cells, and the bottom 14 were adjudicated to be dysmorphic red cells. And it really just illustrates the variability in the shape of red cells, even within a normal urine sample, which you go from the very typical red cells to these ones that are more crenulated and irregular looking, whereas the dysmorphic red cells, some of these are relatively subtle in terms of their membrane blebbing, up to these ones that are 25 to maybe 24 to 28 that are easy to recognize as the kind of traditional Mickey Mouse ears that we learn about in medical school of acanthocytes. The same group showed that with Sternheim staining, which stains the nuclei, you can make it easier to identify what the different elements are. So on the right-hand panel here, you've got the stained cells. You can see the neutrophil in the first panel that's got that large eccentric nucleus. The squamous epithelial cell is quite relatively easy to identify. The urothelial cell can be differentiated from the squamous epithelial cell because it's got a very large nucleolus that is similar size to the nucleus. And then the renal tubular epithelial cell can take a couple of different forms. You see two different types here, where the using the stain really makes it easier to differentiate the renal tubular epithelial cell from the neutrophils in particular, because you can see the difference in the size of the nucleus versus this more typical cell that we would recognize more easily. So the limitations of using the urine sediment exam in acute kidney injury is that it's really not clear if serial exams would improve the prognostic or diagnostic ability. There have been no studies that have shown that urine sediment exam has altered outcomes. I would say that this appears to be in common with pretty much every other biomarker or most other biomarkers that are on the market for acute kidney injury at the moment. But the challenging piece, I think, with the urine sediment exam is that there is this very considerable inter-observer variability in terms of both agreement and accurate identification of the urine elements. One of the few studies that tried to formally examine this, Ragnar Paulsen did a study in 2020 where he had 14 nephrologists review images of urine sediments and study questions based on 10 patients who underwent a kidney biopsy. There was 59% agreement for casts and 69% for other elements. However, the greatest agreement was in the setting of glomerular disease, where there was more than 90% agreement on dysmorphic red cells. So these were 14 nephrologists who were considered skilled in urinalysis. And again, even in this group, the level of agreement was relatively low, highlighting the issues with using urine sediment for diagnostic purposes. Okay, moving on to leukocyturia. So white cells in the urine, greater than 3 white cells in the urine is considered abnormal. It is most commonly related to infection, but sterile pyuria affects up to 14% of women and 2.6% of men. And the evaluation really is determined by the presence or absence of symptoms and the presence or absence of renal dysfunction. So what are the causes of sterile pyuria that are infection related? Commonly recent or current antibiotic use, gynecological infections, sexually transmitted infections such as gonorrhea, chlamydia, mycoplasma, and ureaplasma. These may require urine PCR rather than a general culture for diagnosis. Prostatitis and balanitis, genitourinary tuberculosis, and then in the correct clinical setting, parasitic infections like schistosomiasis can present with sterile pyuria, as can appendicitis, where there's a pelvic appendix that's abutting the bladder. The non-infection related causes of sterile pyuria include catheterization or instrumentation, urinary fistulas, interstitial cystitis, pelvic irradiation, bladder tumors, renal calculi, interstitial nephritis, glomerulonephritis, polycystic kidney disease, papillary necrosis, and renal vein thrombosis are the main kidney-related causes of sterile pyuria. White cell casts, as shown here, are a sign of intrarenal inflammation. This is typically associated with interstitial inflammation, and white blood cell casts can be seen in the urine really with many types of glomerulonephritis, but typically associated with acute interstitial nephritis or pyelonephritis. When we talk about white cells in the urine, this always raises the question of interstitial nephritis. And so we sometimes think about urine eosinophils in terms of the diagnosis of acute interstitial nephritis. This is a nice study that examined this formally in terms of the utility of urine eos as a diagnostic tool for interstitial nephritis. So this was a cohort of 556 patients who had urine eos sent and also underwent renal biopsy, of which 133 had biopsy-proven interstitial nephritis, and 80% of those were drug-induced. So on analysis, if you look at a 1% urine eos cutoff, this had a 30.8% sensitivity for interstitial nephritis, but was specific at 68%, having a very poor positive predictive value of only 15.6%, but a relatively higher negative predictive value. If one used a more stringent 5% urine eos cutoff, the sensitivity was even lower, but the specificity was better. I found this particular, if I can advance here. Yep, this particular image from the paper is, I think, very informative, where this looked at urine eosinophils in other forms of kidney disease. So just to orient you here, the very dark black panels are greater than 5% urine eos. The gray is 1 to 5% eos, and the white is less than 1% eos. And interstitial nephritis is the first column here. But what you can see is that if we compare interstitial nephritis to acute tubular necrosis here, crescentic GN, proliferative GN, and other forms of kidney disease, urine eos distinguishes very poorly between interstitial nephritis and other forms of kidney disease. So it's very little utility in terms of diagnostics. Moving on to hematuria. So in the urine dipstick will be positive for blood in the presence of red blood cells, hemoglobin, or myoglobin, whereas the urine microscopy is positive with greater than 2 red cells per high-powered field. The prevalence of isolated microscopic hematuria varies according to studies. It's reported as anywhere between 0.18% and up to 16%. However, of renal interest when we talk about microscopic hematuria, what we are really interested in is the presence of acanthocytes. So when there are greater than 5% acanthocytes in a urine field, this is highly specific for glomerular bleeding. And again, showing you some more images of acanthocytes across phase microscopy. So a specificity of about 98% and a sensitivity of 52%. How does one work up hematuria? The recommendations are, first of all, to confirm with a repeat sample with microscopy. If consistently present, patients should undergo CT urography. Cystoscopy is recommended, particularly for those who are over the age of 40 or have risk factors. Urine cytology should be checked, and this has a 90% sensitivity for bladder cancer, but is poorer for upper tract tumors. If we look at the differential diagnosis of isolated microscopic hematuria, we can divide it into glomerular and non-glomerular causes. So the glomerular causes are typically IgA nephropathy, thin basement membranes, and familial nephropathies, whereas the non-glomerular causes are urologic malignancy, again emphasizing this point around age, kidney stones, cysts, papillary necrosis, metabolic abnormalities, including hypercalciuria and hyperuricosuria, infection, and then viral or hemorrhagic cystitis can also cause isolated hematuria. In patients who are over the age of 45, about 20% will have an abnormality on the urologic workup, and half of those will be malignancy. However, if patients are under 45, only a small percentage will have significant urologic disease. And so the American Urological Association has this particular schematic for evaluation of asymptomatic microscopic hematuria, starting with history, physical examination, repeat urinalysis. If it's still present, checking kidney function, cystoscopy, and imaging. If there's a reason to worry about the kidneys, then one starts to look for nephrologic abnormalities. If an abnormality is identified, it should be treated. However, if nothing is identified, then this should be followed with one urinalysis yearly for at least 2 years. And if this is persistent, consider repeat follow-up within 3 to 5 years, if clinically indicated. There's a lot of debate around how frequently or how early this repeat evaluation should be carried out. And I think a lot of the thinking around the repeat evaluations is determined by the risk factors the patients have for having an underlying urologic malignancy. What about glomerular disease as the cause of isolated microscopic hematuria? Obviously, there's not a lot of biopsy data because we have traditionally not biopsied patients who only have microscopic hematuria. This study from the 1990s looked at 165 patients who underwent kidney biopsy for hematuria. Of those, 46% of them had an abnormal biopsy. As one might expect, around a third had IgA nephropathy. And then there were a range of other conditions, including thin basement membranes, membranoproliferative glomerular disease. A small percentage had a focal proliferative GN and other abnormalities. And about 7% of this young cohort, the mean age here was 37.5 years, had an abnormal cystoscopy with bladder stones, some local bleeding, and some cystitis. So this would fit with the other observational data that's been shown. I think what's interesting and perhaps has become increasingly relevant as our management of chronic kidney disease has changed in the last few years is this particular study from 2011, which was a large epidemiologic study looking at the outcomes of isolated microscopic hematuria in young adults. So in this particular study, 1.2 million candidates for the Israeli army were screened. These were very young people between the ages of 16 and 25. 0.3% of them were found to have isolated microscopic hematuria. They were worked up by a nephrologist. And so those that had GFR abnormalities, albuminuria, structural abnormalities, these were all excluded from this particular cohort. And the follow-up of this study was over the 20-year follow-up in these young people. Those that had isolated microscopic hematuria had this very marked increase in lifetime risk of end-stage kidney disease, which was primarily driven by risk of glomerular disease. So they had a hazard ratio of 32 for primary end-stage kidney disease for primary glomerular disease compared to those without hematuria. The numbers here are relatively small, but the difference really starts to arise by about 10 to 15 years post-follow-up. And again, I would emphasize these were people who were 16 to 25 at the time of screening. So this was early in life. So I think given the availability of SGLT2 inhibitors, given the changing field in terms of managing IgA nephropathy, because presumably a large proportion of these patients had IgA nephropathy, this again emphasizes the need for us as nephrologists to follow these patients when they do present, even with minor urine abnormalities, because they are at a lifetime increased risk of negative outcomes. Okay, so I've got a couple of cases. So this is the first one for discussion. A 35-year-old male comes for review after dipstick hematuria was detected on an insurance medical. He is a non-smoker and has no hypertension, renal impairment, or proteinuria. He reports no family history of kidney stones or end-stage kidney disease, but his maternal grandmother has a hearing aid. CT urogram is unremarkable. His urine sediment analysis reveals 8 to 10 non-dysmorphic red cells per high-powered field, but no casts. So what is the most likely underlying abnormality here? Does he have a defect in the alpha-5 chain of type 4 collagen, a defect in the alpha-3 chain of type 4 collagen, a defect in the gene encoding PC1, a defect in the UMOD gene, or a defect in the gene encoding alpha-1 chain of type 3 collagen? And I'm going to give you a few seconds to review this. Okay, great. So we have a range of answers here, but it seems like a small, well, no, we're pretty split. Mostly split between option A and option B. Okay. So the correct answer here is option B, a defect in the alpha-3 chain of type 4 collagen. So let's work through why this might be. So PC1 or polycystin 1 abnormalities are caused by gene mutations in the PKD gene. So this is the commonest cause of adult polycystic kidney disease. UMOD gene encodes uromodulin and TAM-Horsfall proteins. The abnormalities in this particular gene are linked to the family of medullary cystic kidney disease, so one might expect to see structural abnormalities on the imaging. Defects in type 3 collagen are linked with Ehlers-Danlos syndrome. However, defects in the type 4 collagen, so X-linked Alport syndrome is a defect in the alpha-5 chain. For this particular case, it's unlikely because there's no family history of end-stage kidney disease or deafness, whereas thin basement membrane disease is due to defects in the alpha-3 chain of type 4 collagen, and that's the most likely diagnosis in this particular scenario. So talk a little bit about thin basement membrane nephropathy. This has a population prevalence of 4 to 9%. This is based on kidney biopsy studies because most patients don't undergo biopsies, but it's clinically seen in less than 1%. Only about half will have a family history of hematuria, but it often falls in an autosomal dominant pattern. These patients have mutations in the genes encoding the alpha-3 and alpha-4 chains of type 4 collagen, and this is essentially a carrier state for recessive Alport. Most patients have microscopic hematuria on routine urinalysis, but rarely patients can present with frank hematuria, loin pain, or acute kidney injury because of heavy hematuria. The diagnosis is a biopsy one based on a GBM thickness of 150 to 225 nanomicrons compared to 300 to 400 in the normal. The prognosis is generally excellent, but there is some association with the development of proteinuria, and more importantly, the abnormalities in these genes have been associated with genetic forms of FSGS. So this is not a 100% benign condition. If we talk about Alport, in these cases, we have also mutations in the genes encoding type 4 collagen, but this is the alpha 3, 4, and 5 chains, which are expressed in the glomerular basement membrane, the cochlea, and the eye, hence the clinical presentation. So 80% of cases have X-linked inheritance. These are mutations in the COL4A5 gene, encoding the alpha 5 gene. 15% are the recessive form, which are the COL4A3 and COL4A4 genes. And then 5% follow an autosomal dominant pattern of inheritance, again with defects in the alpha 3 and alpha 4 chains with slower progression. Patients typically present with a family history of CKD and deafness, but this can be absent in 15%. The clinical presentation is macroscopic recurrent hematuria, which is temporarily linked with respiratory infections in childhood, and patients then develop hypertension and proteinuria. There can be ocular and sensory neural hearing loss, and this tends to progress at the same rate as the chronic kidney disease. In the X-linked and recessive forms, we see end-stage kidney disease between the ages of 16 and 35, so very early in life, whereas the dominant forms tend to present after the age of 45. So let's talk about another case of macroscopic hematuria this time. So this is a 78-year-old male who presents with dyspnea, increasing edema, and is found to have AKI. He has dark urine and decreased output for the last 3 days. He was recently diagnosed with atrial fibrillation and started on warfarin. A week ago, his INR was 4.8, and today it's 1.5. His creatinine today is 3.5 from a baseline of 1.7. His urine sediment shows large numbers of non-dysmorphic red cells, but no casts. Which of the following is correct regarding his presentation? So his clinical presentation may relate to his treatment for AFib. His prognosis for renal recovery is excellent. His presentation is suggestive of a type of cardiorenal syndrome, type 1, or C3 would be increased with this presentation. And I'll give you a few seconds to respond. Great. Okay. So we have one clear winner in terms of your thinking, and I agree. So the clinical presentation most likely relates to the treatment for his atrial fibrillation. So the main differential diagnosis here would be warfarin-related nephropathy or possibly renal atheroemboli. This is a condition where the prognosis for renal recovery actually is quite poor. If we talk about the cardiorenal syndromes, this would be more a type 3 cardiorenal syndrome where it's an AKI affecting the heart rather than type 1 where it's primarily cardiac. Renal atheroembolic disease can be associated with complement consumption and can sometimes present with decreased C3 rather than an elevated C3 as we put in the scenario. So warfarin-related nephropathy, this is initially described in a biopsy series of 9 patients with unexplained acute kidney injury on warfarin therapy. The biopsies showed occlusive red cell casts in the distal nephron, red cells within Bowman's space, and dysmorphic red cells on electron microscopy. All of the patients involved had underlying CKD, and of those 9, 6 of the 9 failed to recover and 4 remained in end-stage kidney disease, so the prognosis was not good. There have been a number of suggested mechanisms for acute kidney injury in this condition, possibly related to glomerular injury, the effect of hemorrhage, tubular obstruction from red cell casts, and then discussion around oxidative stress and iron injury to the tubules related to the red cells therein. So this is diagnosis has now been broadened to, and people now call it anticoagulant-related nephropathy. This essentially is diagnosed as unexplained AKI within 1 week of an INR greater than 3, but has also been seen with initiation of DOACs. It is thought to occur in up to 20% of patients who are starting an anticoagulation, and the risk appears to be highest in the first 8 weeks following initiation. Observational studies have suggested that this is associated with accelerated progression of chronic kidney disease, and patients who experience this do appear to have increased mortality within 1 month. I think in these studies, it's difficult to differentiate how much of the effect was from the AKI versus how much of the effect is from whatever the driver to start the DOAC was, but certainly patients who develop AKI or severe AKI within a number of weeks of starting an anticoagulation appear to have a poorer prognosis. And so just to wrap up, in the urine sediment analysis, I would emphasize it's worth taking a look at the urine itself yourself. It does give kind of a window into what's going on in the kidney. I hope I've convinced you that the urine sediment has many of the expected characteristics of a biomarker, and there are good reasons why what you see may differ from what's on the lab report, and that's to be expected. In cases of leukocyturia, if it's unexplained, it's worth considering those infectious causes associated with negative cultures, particularly in immunosuppressed patients, thinking about sexually transmitted conditions, and then urine infections like mycoplasma and ureaplasma. Urine eosinophils have little or no utility in the diagnosis of allergic interstitial nephritis. I didn't show the data today, but there is a lot that's out there indicating that microscopic hematuria appears to have prognostic information in IgA nephropathy. And I would emphasize that asymptomatic hematuria is commonly urologic in origin in patients who are over 40, and it's worth considering repeat screening in those who have a negative initial screen. Isolated asymptomatic hematuria is associated with increased risk of end-stage kidney disease and long-term follow-up. We talked about the defects in collagen. So Alport is a defect in the alpha 3, 4, and 5 chains of type 4 collagen, and thin basement membranes is where we see defects in the alpha 3 and alpha 4 chains, so the carrier state for recessive. And if you see AKI in recently anticoagulated patients, it's worth thinking of anticoagulant-related nephropathy, and it can be seen with both warfarin and the DOACs. So those are my disclosures again. These are some references, and thank you very much for your attention.